Don't miss this cardiac sign. Pulsus paradoxus is an abnormally large drop in blood pressure due to a decrease in stroke volume during inspiration. A drop of 10 or more millimeters of mercury is significant. Classically, this may present with beats being heard on auscultation that cannot be felt during palpation of the radial pulse, and this should raise alarm for cardiac tamponade and severe pericardial effusion. The physiology is this. When inspiring, there is negative intrathoracic pressure. This helps venous return and increases right atrial filling. Dilating the right atrium will bulge the intra-atrial septum and reduce the volume of the left atrium, therefore reducing left ventricular preload and subsequently systolic blood pressure. In cardiac tamponade, we have a different situation. We have fluid in a non-compliant space, the pericardial space, and this applies an equal pressure on all 4 chambers of the heart until they match the pericardial pressure. Normally, left ventricular pressure is significantly higher than right ventricular pressure, so a small increase in right ventricular pressure during inspiration is not able to bulge the ventricular septum. But in tamponade, the pressure equalization allows a state where not just the atrial septum can bulge, but the ventricular septum can bulge. Now, when the right atrium and right ventricle receive more blood volume, it will push the septum of the left ventricle and reduce left ventricular volume, resulting in a reduced cardiac output. Another significant sign to look out for in these patients is an ECG trace with QRS complexes that alternate amplitude and or axis with each beat. This is electrical Alternans. With a significant pericardial effusion, as is seen in tamponade, the heart is no longer rigidly fixed in place within the chest. Each cycle of the heart, it will move or swing, and this can even be visible on an echo. The ECG leads that you've placed on the patient, however, will remain in a fixed position, but the heart will move relative to them, so each beat, the distance to each vector changes, and therefore you get a different amplitude and or axis. This will typically settle into a repeating pattern each cycle, while you might get a tall QRS and then a short QRS. And this is a physical movement of the heart that is being seen on the ECG, and not an abnormal conduction.